Hi there, I'm Manusha Thomas, and I'm honored to present our study on the comparison of clinical profiles, treatment and outcomes of type 1 and type 2 autoimmune pancreatitis with immune checkpoint inhibitor pancreatitis, a type 3 AIP. As we all know, there are two established forms of AIP. Type 1 is a pancreatic manifestation of IgG4-related disease, while type 2 is a duct-centric pancreatic injury that is often associated with IBD. Immune checkpoint inhibitor pancreatitis occurs secondary to an enhanced nonspecific inflammatory T-cell-mediated immune response triggered by CTLA-4 and PD-1 or PD-L1 blockade therapy for advanced malignancies, as is depicted by the figure in front of you. The enhancement of normal immunity leads to an unwanted immune-related adverse event. Our study aims to describe the clinical profiles of all three forms of AIP by a retrospective analysis of data sets comprising the clinical profiles and outcomes of the three forms of immune-mediated pancreatic injury as described by us previously. Our sample comprised of 50, 43, and 77 patients with types 1, 2, and 3 AIP respectively. The median age of patients with type 1 and 3 is noted to be higher than that of type 2. We found no difference in the proportion of males among the three types. In terms of clinical presentation, types 1 and 2 routinely present with an obstructive jaundice, while type 3 presents with an asymptomatic elevation of lipase. It is because of this asymptomatic clinical presentation and the lack of impact on clinical management that none of the patients with type 3 AIP are evaluated for histologically. In terms of imaging abnormalities, type 3 AIP almost never presents with the routine typical diffuse sausage-shaped swelling of the pancreas as is noted in types 1 and 2. Similar to type 1 AIP, over half of the patients with type 3 AIP have immune-related other organ involvement. However, the organs affected and their presentations are distinctly different. While the pancreas is the most commonly involved organ in IgG4-related disease, type 3 AIP is relatively rare among immune-related toxicities related to ICI therapy. While the definitions for steroid response may vary, we note that immunosuppression seems to improve all three clinical entities. Similar to type 1 AIP, type 3 might also pose some long-term exocrine and endocrine pancreatic insufficiency, although this risk is substantially lower. We therefore conclude that checkpoint inhibitors may cause a rare form of autoimmune injury to the exocrine pancreas that we call type 3 AIP that is distinct from both types 1 and type 2 AIP. Thank you for your attention.